Okay, let's continue with Chapter 7, Part 2. I'm going to go through the review questions at the end of the chapter, as well as some other topics I would like to discuss, and that will be on the exam for this chapter. Number 2, a new patient was seen in the physician's office for abdominal pain. The physician performs a detailed history and comprehensive exam. Medical decision-making is of moderate complexity. I've answered those questions that I advised you in the first part of this podcast, Part 1, that you would ask as a coder. It is an office or other outpatient service. The fact that it is initial or subsequent or critical care does not apply in this case. It takes place in the physician's office, and it is a new patient, which is what the documentation tells us. So having answered those questions, we look up in our index the main term, evaluation and management, subterm office and other outpatient, and we get the code range of 99201 through 99215. And when we go to those codes and read through the descriptors, we want to find the code that properly reflects a detailed history, a comprehensive exam, and moderate complexity medical decision making. I recommend looking at the tables there in the front of the CPT code book. Under there's one for office and other outpatient services for a new patient. Look for those, and you see that a new patient has to have all three key elements. And that means when you look at that table, you cannot choose 99204 because that would require a comprehensive history, a comprehensive exam, and moderate medical decision making. So we cannot choose 99204, so we drop down a level to 99203, and that allows us to capture that detailed history. It was not comprehensive, so we had to drop down to the 99203. For number 4, new patient again, physician's office, expanded problem-focused history, a detailed exam, and low complexity medical decision making. Evaluation and management is the main term. Office and other outpatient services is the subterm. The same code range, 99201 through 99215. I would look again at the E&M tables near the front of the CPT code book under office or other outpatient services for the new patient. Again, it needs all three elements. So we cannot choose 99203 because our history is not advanced enough. We would drop down a level to 99202. For number 6, the physician provides E&M services for a patient in acute hysteria admitted to the ED. So the ED is now your place of service, and you're going to be looking at codes that reflect that. Evaluation and management would be your main term, emergency department your subterm, giving you a different code range. Now you're in 99281 through 99288. Look at the tables again in the front of the CPT code book under emergency department, and you see that it doesn't matter if you're a new or an established patient. You have to have all three key elements to assign a code. And code 99281 is problem-focused history, problem-focused exam, and straightforward medical decision-making. For number 8, we're back in the physician's office with an established patient. This is a problem-focused history, expanded problem-focused exam, and low complexity medical decision-making. Go back to the tables, looking at established this time, established patient under the office or other outpatient services. With an established patient, you only have to have 2 of the 3 required components to assign a code. We have 2 of the required components to assign 99213, so that's the code that we select. For number 10, you have a patient being seen in the doctor's office again, a new patient. I'm going to go back to those same tables. You can either use the index or the tables. To me, the tables are the most helpful. We do not have the comprehensive exam needed to assign 99204, so we must drop down a level to 99203. There may be other logic that you may read about or understand to help you select the right code, but to me, when I see that I have 2 of 3 levels to assign a certain code, but I don't have 3, then I just drop down a level to the next lower level, and that gives me the right answer. That may not make sense to some of you, and there may be other ways of looking at that logic. That seems to work for me. Number 12, you've got an established patient back in the doctor's office, much more information given in the documentation, with a detailed history, expanded problem-focused exam, and moderate complexity decision-making. Go back to our tables. For an established patient, you have to have 2 of the 3 required components, and we have 2 of the 3 to assign 99214. We have detailed history and medical decision-making of moderate complexity. Here's an example that's not in the textbook. It's important for you to know this, and it will be on an exam. A patient diagnosed with hypertension visits her physician's office on a monthly basis. The nurse conducted the blood pressure check under the physician's supervision. Code the office visit. Well, we do not have the physician seeing the patient, but we do have a situation where someone, another qualified healthcare provider, is providing a service under the physician's supervision. So there's only one code in the office visit range of codes that fits that description, and that is 99211. It is assigned for a visit that does not or may not require the presence of a physician. It's a very low-level code, probably has a low-level reimbursement tied to it, I'm not sure. But it is often a test question and one that you should be familiar with. Another example not in the textbook is nursing facility care. You notice that we have a skilled nursing home visit. The date of service is 1914, and the last date of treatment was 12/22/13. The fact that their last date of treatment is listed tells us that this is not an initial visit, this is a subsequent visit. So we look at the subsequent visits in the nursing facility, and the documentation tells us it's a detailed interval history, comprehensive exam, and medical decision making. There is a subsequent nursing facility care table that we can use. It requires 2 of 3 components, and we have those: detailed interval history and moderate complexity and medical decision making, taking us to 99309. Here's another example not in the textbook, and one that we often see on exams: case management services for anticoagulation management. And I have some history here for this so you can understand why a patient might be receiving warfarin. The drug is called warfarin or Coumadin, and either one's the same drug, either name, and it is an anticoagulant that keeps the blood from being too thick, meaning clotting too easily. When a patient has a valve replaced, in this case our patient is having an aortic valve replaced, the consistency of the patient's blood has to be monitored, and you'll hear someone refer to the blood being too thin or too thick. And too thin means the patient's bleeding too easily, and too thick means the patient's blood is clotting too easily. So there's a management there of that level to be sure that the patient's getting the correct amount of the anticoagulant. The test that's conducted is called an INR, or a blood Coumadin test, because the physician is looking at those values for the INR to determine and adjust the patient's Coumadin medication. The results are evaluated by the physician, dosage is adjusted. So in this case, Mr. Nicholson is seen in the physician's office for anticoagulation management since his aortic valve was replaced. What CPT code would the physician bill for the monitoring and management of the warfarin therapy for the initial 90 days of therapy? When you look in the index, I do not find this code. So it's important for you, if you find it, let me know so I can adjust my slides, but I could not find it. I instead went to the E&M chapter, looked in the table of contents because I know it's there, found the case management services, and then found those codes for anticoagulation management. You see that 99363 is for the initial 90 days of therapy with a minimum of 8 INR measurements, and then 99364 is for each subsequent 90-day period with a minimum of 3 INR measurements. There are guidelines just above these codes in the CPT code book that tell you exactly how you would assign these codes. Another example, not in the textbook, but one that you will see on exams, is preventive medicine services. The case we've been given is an established patient, 55 years old, is seen for his annual physical. He has significant pain, soreness, redness, and heat in his right extremity. The condition requires the physician to ask additional questions in his history, do additional examinations, and evaluate through medical decision-making if this patient has phlebitis, which is like an inflammation of a vein in his extremity. In a case like this, both the preventive service code and the problem-oriented service code are going to be reported. There are guidelines just in front of these codes in preventive medicine that tell you when an abnormality is discovered during a preventive medicine session, the appropriate office visit code should also be reported if the condition proves significant enough to require additional workup, which it did in our scenario. Modifier 25 is added to the office visit code to indicate that the same physician provided a significant and separate E&M service on the same date as the preventive medicine service. So you have your preventive medicine service code first, 99396, which is selected based on the patient's age. Our patient's 55, and that takes us to 99396 code. And then we know we're going to use an E&M service code. I selected problem focused because it's really all the documentation tells us, and that would take us to 99212. And I added a modifier 25 to indicate to the payer, the insurance company, that the same doctor provided these 2 services to the same patient during the same visit. If you don't add that modifier, the doctor's not going to get paid for one of those. The insurance company has software that's going to pick up on that, the fact that you're billing 2 E&M codes for the same date of service. So that 25 modifier alerts the insurance company this is a different situation. This modifier indicates that this physician did indeed provide 2 services to the same patient, the same date and the same episode of care. Now let's talk for a bit about critical care services. This category involves the care of critically ill patients in a medical emergency that requires the constant attention of the physician. The constant attention does not have to be continuous on a given date. In other words, he can be in constant attendance for a 4-hour period, walk away, do something else, come back, 4 hours later come back for another 2 hours to be in constant attendance with this patient. So time documentation is so important when we're using critical care codes. The types of emergencies that might require this kind of service would be a cardiac arrest, a patient in shock, bleeding, respiratory failure, or severe post-operative complications. There is a coding tip in your CPT code book that you should always be looking for. They're so helpful, and they outline which services are included in these critical care service codes. For example, pulse oximetry, where the patient has a little thing on his finger that's going to indicate his oxygen levels. That's one thing that would be covered under critical care services. So that you are billing appropriately, you need to know for sure what is covered under that code. If you have services being provided that are not covered under that code, then you would want to be coding for those. So you always want to read those coding tips. If your patient is a neonatal or a pediatric patient, those are different codes. So be sure that you make a mark somehow in your code book to know these are adult codes and these are the babies, the neonatals, and the pediatric, or the patients younger than 24 months. Time is a key factor when you're selecting a critical care code, so you will always be watching for that documentation. Code 99291 is the first 30 minutes through 74 minutes on a given date. That's reported only once per date. If you have additional time after that first 74 minutes, that would be code 99292 for each additional 30 minutes of care. So depending on your scenario, you might have 99292 reported several times to account for each 30-minute period. Critical care of less than 30 minutes is reported with an E&M code. For example, if it's an inpatient, you'd probably be coding under a subsequent hospital inpatient services category. Read the guidelines found just in front of the Critical Care Services Code. These address ambulance transport, those doctors who are in attendance with the people caring for the patient while the patient is being transported. As I said earlier, time spent with the patient is recorded in the patient's record. Any time spent in activities that occur outside the unit, off the floor, or elsewhere in the hospital may not be reported as critical care, because in those cases the physician is not immediately available to the patient. And here's an example, not in the textbook, critical care service. You will see this on exams. The first hour of critical care of a 65-year-old male with septic shock following relief of ureteral obstruction caused by a stone. You see, when you go to the evaluation and management, your main term, critical care is your subterm, takes you to that range of code, either 99291 or 99292. The selection of the code depends on the amount of time that's documented in the patient's record. This documentation tells us the first hour, which is the first 60 minutes, so that's going to fall within the range of 30 to 74 minutes, which takes us to code 99291. Same situation, but notice that after the first hour, the physician left the nursing floor and went to his office where he telephoned the patient's family physician. Can the physician bill critical care service for the time he spent talking to the family physician in the office? And the answer is he cannot. He cannot bill critical care because when he was talking to the family doctor in his office, he was not available to the patient. And the guidelines tell us that time spent in activities that occur outside of the unit or off the floor may not be reported as critical care since the individual is not immediately available to the patient. Please, please pay attention to these last few slides. You will see these on the exam, and I want to be sure that you have read about them in your textbook and in the CPT code book and be familiar with them. Any questions related to the Chapter 7 Part 2 review, please post them in discussion board and I will answer them, and I hope you have a good day.